Welcome in. We are going to be doing a pretty long session today over week one's content for exam three that had gotten, it was muted. We're also going to go over the med sheet for exam three, and then we're also going to go over the stuff that was at the end of week two's PowerPoint about the newborn. Okay. If you go ahead and sign on the QR code. Okay, this part's going to be about normal postpartum and breastfeeding. Okay. Just some definitions. Postpartum is that period after birth to 6 weeks. When we see the term involution, that's meaning it's a rapid reduction in size and the conditions of the uterus to its non-pregnant state, but it will be slightly larger. We have some factors that can speed up this process. Maybe it's an uncomplicated delivery experience, breastfeeding, if they get up and moving, ambulating, and the fact that we have a completely expelled placenta will also speed up this process as well. Things that can slow it down would be if you have a complicated L&D experience, whether it's be a prolonged labor, the whole depression of anesthesia, slowing things down. The more para they are, that will also slow down as well. Maybe they have a full bladder, or maybe they have an infection going on, or just an overdistension of the uterus, which could be from a full bladder. Okay. This next part's going to be really about bubble he. Okay. Bubble he is the kind of thing that can help you know the order of the postpartum assessment. Starting out in starting with our breast here, and I have some of my notes here, so we can really get you guys the whole thing. When it comes to the breast, we're making sure that they are, first we have to ask if they're going to be breastfeeding or bottle feeding. We're palpating to see if there's any engorgement or tenderness going on. We're checking their nipples to see if there's any redness, cracks, or activity, if they're going to be planning on nursing. Some of the alterations could be, if it's a reddened area, that could be mastitis. Maybe it's got a palpable mass. Maybe they're engorged. Tender could be another thing of mastitis as well. And then, of course, with the breastfeeding. Okay. Within our uterus, it's really important as the nurse to make sure that we are massaging that fundus. We want the uterus to be involuting. We have to be pretty much assessing what's going on. The uterus, we have to see if it's firm or not. Firm would not be a good thing. And then, of course, well, firm is a good thing. I'm sorry, it's the boggy that's not a good thing. We're determining if it's firm, and we're also trying to check the position of it. Is it midline? The fundus should be about 5 centimeters below the umbilicus post-delivery, and then after that, it's going to rise to the umbilicus again in about 6 to 12 hours. There's a correlation in the funnel location, actually, and it's about 1 centimeter each postpartum day. So the significance of this would be first days, 1 centimeter, 3 days postpartum should be 3 centimeters. The fundus should be well contracted and firm in order to stop the uterines from bleeding nonstop. A boggy uterus is associated with excessive bleeding. With that being said, the most important thing to do, of course, once the placenta out, is to get that thing moving. Make sure that blood comes out, and the contractions will, of course, be a good thing. But, yeah. Okay, within our bowels, we're assessing if they're having any flatus, we're looking for distension as well. Of course, we're also going to auscultate all the bowel sounds of our post-op clients. So those ones that are in this recovering from a C-section. They should have all their normal bowel sounds, about second or third day postpartum. Of course, constipation may be there as well, maybe from an episiotomy, maybe their fear of hemorrhoids, and then of course any peri-trauma as well would make this process kind of hard. All right, within our bladder, it's important to know that these clients should be voiding pretty soon after delivery. It's about 6 to 8 hours that they should be voiding. We're trying to really look for maybe any UTI. Within L&D, if any of our patients are getting a catheter, you know, we have to make sure that's sterile because that could cause a UTI. So that's why we're checking after this. We're checking their frequency. We're checking if it's burning upon urinating, urgency, which all these things could indicate a UTI. Within our lochia, we're looking for the type, the quantity, the amount, and the color. We have some expected findings here with our bleeding here. The first 1 to 3 days, it should be a red. 3 to 10 days, it should be a serosa pink. And then 10 to 3 weeks or 10 to 21 days, it should be, it'll be called linea alba, creamy white, lochia alba, sorry. Alterations, maybe we have lots of clots, lots of bleeding, foul-smelling lochia. Maybe it's a subinvolution where it's failing to progress normally to the rubra from the serosa. Pretty much with episiotomy, we're looking to see if there's any redness, edema, ecchymosis, discharge. Are there any hemorrhoids? And present, and if present, should be small and non-tender. And then of course, alterations would be the opposite of that. Okay, Hohmann's sign is pretty much, it's pain in their calf. When the client kind of does a little movement with it, what's called a dorsiflex of the foot. If that can happen sometimes whether they're stretching or walking, so we're really trying to see if they have pain. If it's positive, that would be the one we don't want. A positive sign may indicate thrombophlebitis. We're also looking for pedal edema, maybe some redness or warmth. If abnormal discharge, if abnormal changes are what's present, we have to assess that pedal pulse. All right, emotional status. We have to assess their emotional status by observing how they're interacting with their family, their level of independence, their energy level, their eye contact with their infant. Of course, within cultural context, checking their posture, their comfort levels while they're holding a newborn. Maybe it's just a teaching thing. Maybe it's something much more than that. Of course, be on the lookout for mood swings, irritability, or crying episodes. We have to determine the client's phase of their postpartum psychological adjustment. Then we're looking for signs of postpartum blues, and I'll be mentioning that in a second of what that actually is. We just have some more high-risk stuff here. Of course, this med will be on our test once again. So here's the slide for, of course, max sulfate. And what it's done, well, here's preeclampsia, eclampsia, but max sulfate is the next slide. And that'll be on our med sheet. So I'll be talking about that in a bit as well. Some more. Alrighty, postpartum hemorrhage here. This chart that's on the right side of the screen will actually be on our next slide, so don't really put too much of an emphasis on that right now. It can be late, it can be early. Postpartum hemorrhage is the leading cause of maternal mortality in the U.S. And really just, we are very thankful that we are in a country that has, although it's the leading cause of mortality, I mean, it's a worldwide occurrence. That being said, if, in any of the non-first world countries, sometimes they might have a postpartum hemorrhage and they have no ability to, get some more blood, or just sometimes, we watched a documentary in Community one time about how we have mothers sometimes that'll have like 8 or 9 kids and they're doing it back to back. Of course, that's risk of postpartum hemorrhage right there, but yeah, just a big topic. Okay, within tone, atony, this is our, we do have risk factors here. Word ascension, maybe it's from a large baby macrosomnic, maybe it's from multiple gestations like twins, a longer labor, maybe a lot of Pitocin has been used, more of our obese patients, and maybe even just a full bladder is what's present. We do have some treatment there. We're first going to massage the uterus. We're going to give uterotonics, and then uterus will be boggy. So that's what we're trying to fix. Alrighty, with thinking of these meds here, we have oxytocin used once again. We have Methergin, Hemabate, also called Caraprost, and Cytotec, misoprostol, which would be giving rectally. All right, trauma. Maybe they had forceps used in delivery. Maybe it was a very fast precipitous birth. Maybe they had C-section or use of mac sulfate as well. And within this one, the uterus is not boggy, but it's firm. But there's still a lot of blood occurring. That could be, especially bright red blood. You're thinking lacerations when we have a bright red blood. A dark red would always be from the posterior side of the uterus. All right, with tissues, it's we talked about this in exam 2, but we have accreta, increta, and percreta. So those are our 3 different things there. The treatment of this is a D&C, dilation and curettage. And what that is it's kind of a, see if I can do this here. It's like it's really just like a hook. And then what they do is you have the uterus, and they kind of, it's very invasive. They go in and, let's say there's a fragment here, and they'll go in and they'll take that out. Okay, postpartum hemorrhage meds. We're going to talk about this on our med sheet that I'll be going over actually, but Methergin is a very potent vasoconstrictor. That being said, with the vasoconstrictive med, a contraindication is going to be high blood pressure. So if we have a patient that, is on metoprolol or is having preeclampsia, those would be things that put this big eye opener that we're not going to be giving this med for that patient. With Hemabate, please be aware, remember both names. You could give both on the test, or you can get one or the other. Don't give this to a patient with a history of asthma due to risk of bronchospasm. Within Cytotec, it's different. I guess just be aware that it's different doses. Of course, we're not trying to ripen the cervix anymore. We're trying to prevent postpartum hemorrhage. So 800 to 1,000 milligrams. Mastitis is the infection in the breast. It's always kind of caused by staph or strep entering a break in the skin around the breast, whether that's from a poor latch, maybe it's poor positioning, Maybe it's just from a poor fitting bra. They're doing breast pumps, or that really just the tissue was traumatized, maybe by a fissure or cracked nipple. Maybe they don't wash their hands before feeding or something like that, and it's just getting in there. Or maybe a poor just drainage of breast milk, because this can happen if milk gets backed up or clogged within the breast. A sign and symptom of this is going to be fever, chills, warm, reddened area. It'll be painful to touch, pretty much like our flu-like symptoms. Care would be emptying the breast and massaging as well. We have pelvic infections, infections within the pelvis. PID, infection in which sexually transmitted bacteria spread from your vagina to the uterus, fallopian tubes, or ovaries. Risk factor of this would be improper pericare, laceration, or episiotomy, or STDs. Signs and symptoms: redness, swelling, pain, abnormal amounts of discharge or color of discharge, pain, burning sensation, itchiness, and odor as well. Within our UTIs, like we said, urinary catheters can be a risk factor as well. This is infection in the urinary tract. Pyelonephritis is when it travels up into the kidneys. Risk factors may be a history of UTIs. Improper hygiene, improper bathroom hygiene, dehydration, urinary retention, and even, remember this, frequent vaginal exams during labor. Once that water breaks, you really can't just, you have to make a purpose with all of your exams. And if you're doing it a lot, be aware of the risk. You could get anything in there that can cause an infection. Okay, signs of this would be hematuria, polyuria, odorless, film over the urine, suprapubic pain, dysuria, flank pain, fever, nausea, vomiting, back pain, and dizziness. Care of this, we're going to teach about, of course, all of our hygiene, antibiotics. We're going to increase fluid intake. That's just really just teaching, but we want to give them lots of fluids. That's without being a thing as well. Okay, thromboembolism. I'm glad we're going back over this on a different recording because we can explain it a little bit differently. The patho pretty much is a blood clot. A risk factor could be preterm labor, eclampsia, a C-section, maybe a smoker, increased maternal age, maybe they're obese, anyone in bed for a long time as well. So definitely C-sections would be one of those. Signs of this would be pain, heat, swelling, redness, abnormal circumference. But really, let's talk about what we have here. The types, we have two types here. A lot of times you're here, what's down here, instead of thromboembolism. Okay, within a superficial thrombophlebitis, this occurs usually about the 3rd or 4th day postpartum. It's signified by tenderness apparent in the end portion of the vein. It can also going to be signified by local heat and redness as well. Within deep vein thrombosis, it's going to be edema of the ankle and leg, pain in the lower leg or abdomen. That pain is resulting from calf pressure, and peripheral pulses may be decreased as well within that DVT. Okay, within postpartum blues, I'm going to gather my notes real fast. All right, back. Okay, within postpartum postpartum anything psychosis, we have three different levels here. I'm going to start off with the most abnormal one, postpartum psychosis. This will be evident within the first 3 months postpartum. Symptoms of this are going to be agitation, hyperactivity, insomnia, mood lability, so they're changing moods often, confusion, irritation, irrational thoughts, difficult remembering or concentrating, poor judgment, delusions. Delusions would be, remember, illusion is thinking something there is something else, but delusions are when you hear or see something that's not actually there. So they could have someone telling them that their baby's Satan, that their baby's going to grow up to be this different thing. So here we go with the risk factors. A risk factor of postpartum psychosis are going to be agitation, hyperactivity. I'm sorry, maybe a previous postpartum psychosis, maybe a history of bipolar disorder, any really overall, just also any prenatal stressors such as obsessive personality disorder or a family history of a mood disorder as well. Okay, within postpartum depression, this is abnormal. Think depression. Okay, this can happen anytime within the first postpartum year. This most often occurs around the 4th week. Okay, symptoms of this are going to be sadness, frequent crying, insomnia, appetite changes, the ability to not even concentrate, make decisions. They might be sitting in bed all day, not being excited, and they're just very emotional and don't want to do anything, don't want to have any interest as a parent at that time. They might have obsessive thoughts of being inadequate as a person / parent. Maybe they're at a lack of interest for all of their usual activities. Maybe they have a lack of concern about personal appearance. Maybe a hostility towards the baby can be seen as well. A risk factor of postpartum depression will be if it's their first child, because they might feel that they're not prepared. They might have just been ambivalent about the entire pregnancy itself. Maybe they have a lack of social support, a lack of a stable relationship with parents or their partner. Maybe they're concerned about body image, and pretty much yes, that was that. All right, with baby blues, this one's the one that's kind of normal. Baby blues typically occurs within the first few days after the infant's birth, and it is self-limiting. Lasting 10 days or longer may actually happen within our first-time mothers, because they're, feelings of being unprepared, things like that. It's thought to have been related to the rapid alteration in estrogen, progesterone, and prolactin levels. So baby blues is usually a fluctuation of hormones after delivery, only the first 1 to 2 weeks after a delivery as well. These new mothers could be feeling overwhelmed. They might not be able to have developed coping skills. They might be really fatigued, anxious, irritable, and oversensitive. All right, now going into a touchy subject, we have grief and loss here. Really things to start out with by saying people do coping with grief in different ways. There's always a loss and a birth. No, you don't know exactly how they feel. Children are not supposed to die before their parents. They're have been preparing for this moment for the past almost 40 weeks, maybe even before that as well, if they may have struggled with conceiving a child. Okay. Starting out with how everyone is affected by loss. Let's talk about siblings first. Siblings that are through the first 6 years of age, they might view death as a temporary, and they might even view that it's reversible. Children in this age may feel guilty that their negative thoughts may have caused the death. Children that are 6 to 12 of age view death as inevitable and irreversible. And then by 12, the kind of normal thoughts about death. Okay, father, they might have a difference in expression or grief, loss of redefining their role. They might lag in attachment or stages of grief. They might even have guilt or self-blame. Okay, we have some things that can be helpful and non-helpful as a nurse, if there ever is a grief with an L&D. It's important to call the child by the name. This is the only time that as a nurse, not only time, but this is a time where you actually are okay to cry with the family to help them grieve. We can also attend the funeral. Well, I guess that's what my book says here, but I don't know. What to do is maybe remember the family on their baby's due date, birthday, or death date, anniversaries. We have things that we could give the family. Maybe photographs of their loved one, a lock of hair, footprints or handprints. Give them the baby ID band that was there for the infant, and the clothes the baby was photographed in. What you can say is, this must be hard for you. I'm sorry. What not to say was, what you don't want to say is, at least it wasn't older. It was God's will. You can have other children. At least you have other children, and time will heal. We have some other non-helpful resources that would be not acknowledging pregnancy or loss, maybe not going into the client's room. You might isolate from their client's room. And then we also have some helpful ones as well. Parents are allowed to choose whether they want to stay on the postpartum unit or another unit away from the nursery. We have to provide a quiet, private setting to allow parents to say hello and goodbye to their infant at the same time. This up here. Okay. Within the ideas of seeing and touching, parents should be informed of the appearance of their child so they can make a decision whether or not to see and touch their child. Many parents are actually reluctant to see and touch their baby initially, but most of them say later that they are glad that they did so. Parents should be encouraged to spend as much time as they want with their infant. Many parents will want to see their infant more than one time, if given the opportunity. This is the only chance they will ever have to see their child. So we really have to kind of really just be their advocate, be there for them and do everything that you can. Infants should be dressed like other infants on the unit, usually a diaper and a t-shirt and wrapped in a baby blanket. The nurse should stay in the room or be really close for support. Within remembrances, nurse should take pictures of the infant dressed in baby clothes and without clothes for the parents. Pictures should be offered to the parents. If the parents refuse these pics, they should actually, you should tell the family that, we're going to keep these pictures on the unit in case you change your mind. Pictures to help the parents accept their child's death and move forward within their grieving process. A lock of hair, one of the baby's ID bracelets, handprints, footprints can be obtained and given to the parents as well. And that's going to be for that part. I'm going to go ahead and pause the video and get on to our next thing. Alrighty. For the last slides here, just go and place that in if you haven't done so. Okay, within our vital signs and measurements of our newborn, we have a huge list here. Their blood pressure is usually 50 to 70 over 30 to 45. The mean millimeters of mercury should not be greater than 60 millimeters of mercury. Their temperature, of course, is 97 to 99. Normal aspirations are 30 to 60. If 80, then they shouldn't feed because of risk for aspiration. The heart rate is going to be around 120 to 160. It can go into the 180s if they're crying, and then down as the 100 to 110 if they're sleeping. Listen to them from when it is quiet. A slush or a slur sound, definitely eval for that. That could be a congenital heart defect. Pulses, we're looking at their breaker pulse, femoral pulse, pedal pulse. Their weight, 2,500 to 4,000 grams. And it can go for anywhere from 5 pounds, 8 ounces to as high as 8 pounds, 13 ounces for their average. Length is going to be 48 to 52 centimeters. And then, of course, if you want to just divide it by 2.54, we're going to 18 to 22 inches. Meconium, common in 24 to 48 hours. Okay, measurements, their weight. 5 to 10% is lost within the first 3 days is normal. Within their head circumference, it should be bigger than the chest in the first few months because remember they are cephalocaudal as they're growing, so head down. So it's normal for the head to be bigger. Within the temperature monitoring, we're doing an axillary temp, a skin probe. Low temp can be fecal infection. A high temp is dehydration. Babies are at a very high risk for dehydration. One of the reasons is because they have trouble concentrating their urine. Okay, we have the head here. Always get a circumference every time that you are assessing, and have the same person or make sure they're measuring it the same way every time. We have some normal things here. We have molding. It's an asymmetry caused by overriding cranial bones during L&D, usually resolved in 2 to 3 days. That's signified, but that's on our left picture right here. Within our fontanelles, we have the anterior. It's going to be around diamond-shaped. Posterior is going to be that triangular-shaped. And then we have 2 different things here. One of them is going to be called the cephalohematoma, one word. It's the collection of blood, hence hematoma, from ruptured capillaries. Make sure it's recording. Okay. That may develop after birth. Cephalohematoma does not cross the suture lines, but a cephalohematoma gives us an increased risk for hyperbilirubinemia. Okay, next would be the caput succedaneum. Really didn't say that right, but this is pretty much, it's not a hematoma, this is just edema. This is edema of tissues which does not cross the suture lines. Oh, please don't listen, it does cross the suture lines. And we have this little thing that Mark Klimek had taught me. Within the actual initials of caput succedaneum, remember that CS means crosses the suture line. So that's very helpful, very helpful. This will likely be seen on your test. So please look over that and write it out. Skin components, we have jaundice. Jaundice is first known on the face, yellowing, blanching over the cartilage and nose. The sclera will then spread down the body. Prevent cold stress, monitor INOs and stooling, teaching the parents phototherapy and how to maintain bonding, breastfeeding. I remember one time I was in clinical and there was a baby there that was in phototherapy and the dad was watching the entire pretty much day. Okay, with integer, assess at the abdomen or the thigh. It should be very elastic. Okay, I'm trying to make this bigger for us. Within skin variations, we have acrocyanosis. This is blue hands and feet. Normal 2 to 6 hours after birth. After, for a day after birth and we still have acrocyanosis, that could be a sign of a CHD, congenital heart defect. Modeling is the lacy pattern of dilated blood vessels under the skin, may come and go, and this is normal. Erythema toxicum is pretty much like a little rash. This is normal. I had this on my exit Hesse actually. Small varied lesions may have papulars or pustules, look similar to acne or ant bites, and this resolves within 2 days. Milia is that small white spots, usually on the face. You'll see it if you're ever in the nursery at Bay or South. You'll see it. It's just like little pores or something. It's kind of white. It's kind of cool. Vernix caseosa is that cheese-like substance on them. You don't have to scrub it off, and it's actually a good skin lubricant. They might have some forceps or vacuum marks. If present, we are evaluating this. We want to assess for drooping. We want to assess for any lacerations, things like that. So that's what it's going to be. Okay, stork bites are that pale pink or red spots on the eyelids, nose, or the neck, and they fade by 2 years. They're going to be kind of a pink little thing on them. I've only seen them once, actually. Within a Mongolian spot, it's very important that we document this because a Mongolian spot is a bluish, blackish pigmentation on the dorsal area or their butt, and it could look like a really big bruise in some cultures. So just document that it's there on the newborn assessment. We have the nevus flammeus. Saying it totally weird, sorry. It's called the Port-Wine stain. This is a capillary angioma under the skin, frequently on the face, usually does not change. Even though we have the nevus vasculosus, this is raised capillary hemangioma, and this can grow rapidly, usually resolve spontaneously. Okay, with our face here, we're looking first at the eyes. making sure they're open. No discharge, hemorrhages on the sclera, tears. We're doing a red reflex, which is where you're trying to see if there's light reflecting off the retina. This would mean that they have, of course, like no cataracts. Looking at the nose, make sure their nares should be patent. Within our mouth, we're doing a pretty big assessment on their mouth because that's, feeding and everything. We want to make sure that's symmetrical whenever they cry. Make sure that there's a hard palate intact and reflexes are present. We're looking at the rooting reflex. Is where the infant turns to the side, stimulated, and opens their mouth to suck. And then as well as the sucking reflex. The sucking reflex is their ability, when you put something in their mouth, they exhibit sucking features. They may have Epstein's pearls. These are insignificant, they usually resolve, but Epstein's pearls are the small white specks on the gum ridges, tongue not protruding. Thrush is white patches on the mucous membranes. It's very painful for the mom. We have to treat the mom and the baby. When you take a little wipe on their tongue, if it is milk, it will come off. If it's thrush, it won't come off. Caused by candida, yeast infection from the mom's vagina at birth. Treat mom and the baby. Can't treat antibiotics, but antifungals or natural remedies. Within the frenulum, that is kind of the part, underneath your tongue, a little thing there. If it's tongue-tied, pulls on the tongue to give it a heart shape. Refer the eval and monitor feeding. We do not want to clip it unless it's symptomatic. Trouble breastfeeding, mom has lacerations on the nipples, impaired speech. Older kids will go under euthanasia for anesthesia for that to be prepared. This is what we're going to talk about with our body. Within our ears, we're checking them. But really, the most important thing is when you have an ear, something abnormal, you have to look at the other body systems because the ears are made the same time as their major organs. Ears also tell us maturity level. If whenever you were to pull your ear closer to your eyes, if it's a term baby, okay, if it's a term baby, it's going to recoil immediately. If it's a preemie, it will stay there when coiled over. Okay, within the neck, we're checking for masses, we're checking for webbing, we're looking at the range of motion. Clavicles should be intact with no crepitus. What does crepitus indicate? A fractured clavicle. The clavicle is the most frequently actual bone fractured in our delivery. And we're also checking the tonic neck reflex. That is when the head is turned to one side, the extremity on that same side will extend, hence this picture, and the extremities on the opposite reflex are on the opposite side of the head facing are going to go ahead and flex. Within the chest, we're looking for symmetry, breast engorgement, assessing the nipples, retractions, what they indicate. Retractions are the best indicator of our respiratory assessment. Okay, cry should be strong, lusty, good medium pitch. A high-pitched cry or shrill. A high-pitched cry or shrill, definitely get an eval. Okay, within breathing, we're counting by observing the abdomen. We're listening, we're looking, we're palpating. Abnormal would be nasal flaring, retractions, or grunting. Within our abdomen, there should be non-distension, few if any vessels. We're palpating and we're also auscultating the bowel sounds. There should be bowel sounds when relaxed. The umbilical cord should be white with 2 arteries and 1 vein clamped with no foul odor. The femoral pulses are palpable and equal. There should be no bulges along the bilateral inguinal areas. We've already kind of talked about this with the umbilical cord. Okay, within the genitalia, for males, there's going to be scrotum with rugae. The testes are descended into the scrotum, the penis with urinary meatus at the tip of the glands on the ventral surface of the penile shaft. The female may have vernix caseosa, that cheesy white substance, over the labia minora, and the smegma increases. Labia majora normally covers the labia minora and the clitoris. Discharge may be present because of the maternal hormones. I think there's something else here as well. No, that was it for that. We have the 3 types of circumcisions. When it comes to the actual types, I don't think you have to know, but I would say maybe to be safe, just search them up in the book to see what they are. Of course, you have like 2 that are kind of natural and the ones look a little different, but and it was a long time ago that I took that exam, so I'm not too sure if that was even something on there, but to be safe, maybe just check it out. Okay, within extremities, we're of course assessing the number of their digits, looking for the range of motion, ensuring that they're equal length. Skin folds should be symmetrical. No openings or tufts of hair at the base of the spine. That could be indicative of spina bifida. Spine should be straight, of course. Erb's palsy, damage to CNS, and cranial nerve 6. Paralysis of the upper arm would be no movement or the moral reflex on that side. We're going to do an Ortolani maneuver, and that's testing for hip dislocation, looking for dysplasia. The way that's going to be performed is you're going to put a fingertip over the greater trochanter. You're going to roll the leg up and out. If you feel a clunk as it's moved, those clicks are not good. That would mean we have congenital hip dysplasia, and it's more common in breech presentations than that of a vertex 1. The treatment of this is going to be a Pavlik harness that's going to be worn pretty much almost 24 hours a day, but not just quite 23 and a half hours a day until the hip is fixed. Within the back, we're looking for a C-shaped spine, flat and straight when prone, slight lumbar lordosis, easily flexed and intact when palpated, at least half the back devoid of lanugo. The full-term infant in ventral suspension should hold head at a 45-degree angle back straight. If the baby has sacral dimples, ensure that those dimples are closed. An open nipple would be something that we're fearful of with a spina bifida or a neural tube defect. Make sure babies are, of course, peeing and pooping before they leave the hospital, because sometimes deliveries can get discharged pretty quick, sometimes under 1 day if it's a smooth vaginal birth. Now we're going to go into the med sheet. Alrighty, team, with our meds here, just really discussing first our uterotonics. We have Pitocin, also called oxytocin. Within our exam here, this is going to be used for postpartum hemorrhage as a control measure. This is contraindicated for severe preeclampsia and cord prolapse. That would be more with our labor delivery, but we have no contraindications for the use in postpartum hemorrhage. We want to avoid an undiluted rapid infusion as it may cause serious hypotension. The expected effect would be a rhythmic uterine contraction that helps prevent or reverse postpartum hemorrhage caused by uterinectomy. Okay, Tom's done. The Methergin med, you might even see this on the exam, methylorgonavine, is an oxytocic med again and is used to make the uterus contract and decrease bleeding. This one is, I always like to say that we have the H there as it's contraindicated in hypertension patients due to its vasoconstrictive properties. If patient does have a history of hypertension, then give Hemabate instead. Of course, unless they're asthma patients. Expected effect would be a sustained uterine contraction that helps to prevent or reverse the postpartum hemorrhage caused by that uterine atony. A side effect, though, would be hypertension. That's why it's contraindicated in hypertension patients. Dizziness, a headache, overdoses will be recognized by present seizures, tingling, and numbness of the fingers or toes. As a nursing consideration, do not give this IV because of the possibility of inducing a hypertensive crisis or stroke. Okay, within our Hemabate, and I'll kind of zoom in so you can see it a little better. Also called carbaprost tromethamine. This is stimulating the uterus to contract and reduces the risk of postpartum hemorrhage. This one is contraindicated with our asthma patients. I'll do this. Or pulmonary disease, as it could cause bronchoconstriction. The expected effects would be the control of the refractory causes of the postpartum hemorrhage caused by uterine atony, generally used after failed attempts at control of hemorrhage with those oxytoxic agents. The side effect could be a headache, flushing, bradycardia, bronchospasm, wheezing, cough, chills, or fever. Within Cytotec, also called misoprostol, this is usually given postpartum to stop bleeding or prevent uterine atony, usually given with an 800 microgram rectally, rapidly affects contraindications in minutes. Contractions, I'm sorry. Within a contraindication of this, as it is a prostaglandin, or a history of or allergy to prostaglandins would be a contraindication with this med. The expected effects could be used to prevent and treat uterine atony after failed attempts to control bleeding with oxytoxics. Okay, within our mag sulfate classification, electrolyte, anticonvulsant, CNS depressant, and tocolytic. Given for preeclampsia and eclampsia, it relaxes smooth muscles much like a sedative. Monitors, we want to make sure we're monitoring the respiration rate status. Also, within the they might have diminished tendon reflexes, diminished being absent. We have to monitor mom for mag toxicity. We're looking at their vital signs, looking at pulse, respiration rate, and blood pressure. Major side effect of this would be lethargic, heat sensation, respiratory depression, and depressed reflexes and cardiac arrest. RhoGAM within, that's going to be our med given to our Rh negative women when they're exposed to an Rh positive blood after abortion, labor, amniocentesis. We have this here though, and be familiar with the wording. I'll not do that. That's hard to read. We have to confirm if the woman is a candidate first. So if there are an Rh negative mother with a negative indirect Coombs test, which means they're not sensitized, and an Rh positive newborn that is not sensitized, a negative direct Coombs test, then they would be viable for a RhoGAM injection, which is usually given within 72 hours of delivery if needed. We have to do a blood type and cross mom's and neonate's blood as well to do this. Erythromycin ordinate, I think it has a different name, and I'll have it in my paper here, but Tyson, but I think there might be another one. Given as soon as the baby is born, within the first 24 hours, you're usually doing this when they're kind of doing their first scale and measurement and stuff like that. So if that's what they might be doing it. Okay, vitamin K, aquamephytin. Please know this, because she very well could put that word instead of vitamin K, and then everyone might be a little confused, but just looking out for you guys. This is used for adequate blood clotting. We're giving this in the vastus lateralis. If you had a question on where they're giving IM meds, nowhere to give it. Vastus lateralis. This is administered shortly after birth to prevent hemorrhagic disease of the newborn. This will, of course, stimulate a clotting factor, and we're educating the baby, them that the baby cannot get circumcised without that vitamin K injection, or else bleeding would just not stop. Checking the blood pressure often and make sure the baby isn't bleeding. Next is going to be Hep B vaccine. Immunoglobulin Intergex, or Recumbivax, provides passive immunity to the Hep B newborn. If the mom is positive, we're giving 0.5 IM for the first 12 hours of life. And that's going to be it. You guys have a good time studying.